Welcome to your Introduction to Movement Disorders. The goal of this introduction is to provide a structured framework for describing movement disorders so that you can determine the correct phenomenology in your patients and work toward making the correct diagnosis. When evaluating a rash, you are taught to describe it using descriptive terms. You don't say this is psoriasis, but rather that the rash is scaly, red, and raised. This is similar to how you should approach movement disorders. In movement disorders, we start with descriptive terms such as oscillatory or flowing in order to work toward the phenomenology of the movement. Phenomenology refers to using observable components of the movement to determine the phenomenon that we are observing. Examples of phenomenologies in movement disorders are tremor, chorea, or other movements which are more fundamental than the ultimate diagnosis. Examples of diagnoses are essential tremor and Huntington's disease. Working from the description to the phenomenology to the diagnosis, we can make informed diagnoses. You can think of movements like Goldilocks thinks of porridge. There is too much, too little, or just the right amount of movement. Too much movement is called hyperkinetic. Too little movement is called hypokinetic. Sometimes there are aspects of both. This is the first descriptor to consider when seeing a movement disorders patient. Hypokinetic movements are the easiest to describe. They may be slow, called bradykinesia, small, called hypokinesia, or absent, called akinesia. These words have precise definitions, but colloquially, in practice, there is a lot of overlap in their use. Often the word bradykinesia is used to describe all three. Hyperkinetic movements are much more complicated to describe. There are a lot of fluid terms that we use, and in some cases there is disagreement even among experts and the terminology is still in flux. This can be overwhelming for a new learner, but I hope that this framework will get you started. There are several categories of descriptors that we think about when we describe abnormal movements. For each movement, you should consider the level of voluntariness, the rhythmicity, the pattern, and the texture or look and feel of the movement. For each phenomenology, we will review which combinations of terms make up the essence of that movement. We will also review some of the more difficult terms in more detail. Tremor, for example, is an involuntary, rhythmic, oscillatory movement. It is generally not described as either stereotyped or non-stereotyped. Oscillatory means that the movement resembles a sinusoidal wave. In tremor, there is alternating agonist and antagonist muscle activity. You can also think of tremor like a seesaw. The agonist and antagonist muscles contract, alternating back and forth. Myoclonus is an involuntary movement that is jerky, related to contraction of a muscle in one direction. The jerkiness of myoclonus can be differentiated from tremor's oscillatory texture, which is related to alternating contractions of muscles, as we have seen. It is usually arrhythmic but can appear rhythmic. Again, we generally don't describe myoclonus in terms of whether or not it is stereotyped. Some myoclonus is physiological or normal. When you think of myoclonus, you can think of hiccups, which are diaphragmatic myoclonus. Hiccups are involuntary jerky movements. In the case of hiccups, they are arrhythmic. Another form of physiological myoclonus is hypnagogic myoclonus, which are the jerky movements that some people get as they are falling asleep. Tics are semi-voluntary and stereotyped. They may be rhythmic or arrhythmic, and they may have multiple textures. Semi-voluntary movements are those that are neither strictly voluntary nor strictly involuntary. Think about a time when you were extremely itchy. You tried not to scratch, but the more you thought about it, the itchier you got until you had to scratch, and then relief. This is similar to what people with tics describe. The urge, or in the case of other semi-voluntary movements, an inner feeling of restlessness, the suppressibility, even if temporary, and relief afterwards are part of what make tics semi-voluntary. So what does stereotyped mean? Take a look at this wallpaper. There are all different types of cats. There are gray cats and tan cats and brown cats. So there are multiple different flavors of cat, but they are all cats and they each repeat in an overall pattern. With ticks, patients may have what we call a battery of ticks. For example, they may have a blinking tick, a grunting tick, and a shoulder shrug tick, and each tick is patterned and repeated. There is some predictability to the ticks. That is what makes them stereotyped. Dystonia is an involuntary, sustained movement. Superimposed on dystonia may be other jerky or tremulous movements, but the essence of dystonia is sustained contraction of muscles. Sustained means that the muscle contractions are more prolonged than in, say, myoclonus. In dystonia, agonist and antagonist muscles co-contract, resulting in twisting or posturing of the body part. Think about arm wrestling, where two opponents are contracting their biceps simultaneously, resulting in maintenance of the fixed posture of the two arms together. This is like what is happening in dystonia. Chorea and athetosis are involuntary, non-stereotyped flowing movements. They are non-stereotyped, meaning that they are not patterned or predictable. Ballism is an involuntary movement that is, as you can probably guess, ballistic, meaning abrupt, high amplitude, and with momentum like a projectile. Often, patients present with combinations of chorea, athetosis, and ballism. These entities are sometimes considered phenomenologically on a continuum, although they can have quite different etiologies. On this continuum, chorea is faster, athetosis is slower, and ballism is larger. Finally, akathisia is a semi-voluntary movement. The urge of akathisia is often described as a feeling of profound inner restlessness. Akathisia may be stereotyped, such as pacing back and forth or rocking forward and back, or non-stereotyped, appearing similar to chorea, and it is flowing in texture. I hope that this introduction has provided you with a framework to start thinking about abnormal movements. You can apply what you've learned when seeing patients with movement disorders, starting with the description and then working toward phenomenology and finally diagnosis.